Good afternoon, everyone. I'm Faith Kwaramba. So today I'm going to take you through the Arnold Chiari Malformation 3, identifying the missed opportunities in the journey of this woman and her pregnancy. So Chiari 3 is the rarest of the Chiari malformations characterized by high cervical or occipital encephalocele and some osseous defects associated with herniation of the posterior cerebral fossa contents through the foramen magnum. So the incidence is about 1 to 3 cases per 10,000 live births. It's a very rare condition. So of the Chiari malformations from 1 to 4, the type 3 has the worst prognosis than types 1 and 2, and it is characterized by a high mortality rate and severe neurological and developmental deficits in the surviving patients. And it is more common in low resource settings like here in Zimbabwe, where limited access to anomaly screening contributes to delayed diagnosis, inadequate folate supplementation, and poor access to the preconceptional care. So why does this case matter? So unlike Arnold Chiari malformation type 2, Chiari type 3 is defined by the presence of an encephalocele with protrusion of the intracranial contents through a skull defect. So this case demonstrates a classic but advanced presentation of Chiari 3 malformation, which was diagnosed late in pregnancy at 39 weeks plus 6 days, complicated by a giant posterior encephalocele associated with severe ventriculomegaly and suspected associated cardiac abnormalities. And it also highlights multiple missed opportunities for the antenatal diagnosis and prevention. So allow me to present a case of Miss MS, who is an 18-year-old housewife from Chinoi. She was in her first pregnancy at an estimated gestational age of 39 weeks plus 6 days. So she came to us at Rare Hospital from Bari, as a referral from Bari Clinic with an ultrasound scan suggestive of fetal defects. So this pregnancy was planned. However, this woman had no preconceptional counseling, and she booked a pregnancy at 12 weeks and had 7 antenatal care visits, and she was HIV negative. However, she had no chronic illnesses and she was not taking any medication. And she stays with her husband in Chinoi, who is self-employed, and they are both not on medical aid. She does not smoke or take alcohol. So in terms of investigations, this woman never had unplanned screening, though she had 7 antenatal care visits. She never had fetal anomaly scan. She was never screened for neural tube defects. No blood tests were done. Full blood count, random blood test was not done. And she was never even screened for congenital infections, the torches screen. So the ultrasound scan, which was done at Salim Gabe FMU, unit showed a single intrauterine fetus with an estimated fetal weight of 3,496 grams, and it was a cephalic presentation. However, of note, there was a large encephalocele measuring 130 millimeters with echoes within it suggestive of herniated neural tissue from the posterior fossa, and it was complicated by severe ventriculomegaly. The left ventricle was 39 millimeters, whilst the right ventricle was 34 millimeters, showing ventriculomegaly. Then in the posterior fossa, the cerebellum had herniated into the encephalocele. And of note, the heart was abnormal. However, the abnormalities were not characterized. So these are some of the ultrasound scan images which are showing the ventriculomegaly that I was talking about. And the defect on the posterior fossa. This is also the images which are showing the ventriculomegaly, both the right and the left, and also the defect which was measuring about 2.7 centimeters on the skull, and there was herniation of the posterior fossa contents into the encephalocele. So on delivery, both this patient has presented to us at term. She was scheduled for an elective cesarean section a week later after presentation. However, she went into spontaneous labor and an emergency cesarean section was done. So the birth weight was 2,820 grams, and she had low Apgars of 4 to 4 to 5 on 10, and she had a large head circumference which was 41 centimeters. And these are the images showing the baby who was delivered, and she was in mild respiratory distress. That's why she's on oxygen per nasal prongs. And this is the encephalocele which was noted. So in terms of progress, this baby is currently admitted at Salim Mugabe neonatal unit, and she is now day 59 of life. The ruptured encephalocele was noted to be septic on day 40 of life, and currently she is on broad spectrum antibiotics. However, she is breastfeeding well, and the current weight is now 3,000 grams. And this is the photo of the baby who is now 50 days of life. So she had a transfrontal ultrasound scan which confirmed the hydrocephalus, and the CT scan brain confirmed the encephalocele with herniated cerebellum tissue. So currently she's awaiting encephalocele repair, which is scheduled for next week on Wednesday. So in terms of preconception, the primary approach to managing the myelomeningocele is prevention. So folic acid supplementation should be started at least 1 month before conception and continued throughout the first trimester, and it helps to prevent the neural tube defects by about 60 to 70%. And it is recommended that women of childbearing age should consume about 0.4 milligrams of folic acid daily. So women with a history of pregnancy affected by neural tube defect should take at least 4 milligrams of folic acid daily starting 3 months prior to conception, like in our woman when she tries to get pregnant again. So the identified gaps in this case are that this woman did not undergo the first trimester aneuploid screening. She did not have a detailed anomaly scan at 18 to 22 weeks, which could have picked all these defects that were noted. And she was never screened for neural tube defects and had limited laboratory investigations. And a routine second trimester anomaly scan would likely have identified the occipital encephalocele, the ventriculomegaly, as well as the abnormal posterior fossa anatomy. So the role of ultrasound scan in this case is that it can diagnose neural tube defects with 97% sensitivity and 100% specificity, minimizing the need for even invasive tests such as the amniocentesis. And the MRI can further characterize the extent of neural tube herniation, even the brainstem involvement and associated CNS abnormalities. So following diagnosis, management should involve a multidisciplinary counseling, including the maternal fetal medicine specialist, the neonatologist, the neurosurgeon, as well as the genetic counselors. And given the severe structural abnormalities and poor prognosis in this baby, offering termination of pregnancy was appropriate and ethically justified. So in terms of timing of delivery, the gestational age and the severity is one of the options. You can do vaginal delivery with immediate closure of the encephalocele. You can do even prenatal closure of the encephalocele at around 26 to 27 weeks of gestational age, or you can do cesarean delivery. However, large encephalocele significantly increase the risk of sac rupture, intracranial hemorrhage, and obstructed labor. So in this case, immediate cesarean section after onset of spontaneous labor was appropriate because of the giant encephalocele and risk of traumatic vaginal delivery. So in terms of postnatal management, the management includes airway stabilization, feeding support, the seizure management, and neurosurgical repair and ventriculoperitoneal shunting for the hydrocephalus. And the surgical repair aims to reduce the herniated contents, preserve viable neural tissue, and close the defect and prevent infection. However, surgery does not reverse the existing neurological injury. So in terms of prognosis, it is generally poor and depends on the size of the encephalocele. Poor prognostic indicators in this case include the giant encephalocele, the severe ventriculomegaly and suspected cardiac anomaly, as well as late diagnosis and brain tissue herniation. And the survivors commonly experience neurodevelopmental delay, seizures, cranial nerve dysfunction, and even feeding difficulties. And the low ABGAS in this case suggests significant neonatal compromise. So in this case, the take-home message is that preconception folic acid supplementation, it remains one of the most effective preventive strategies, and routine first trimester screening and the 18 to 22-week anomaly scan are critical for early diagnosis of this condition. And delayed diagnosis limits the reproductive options, the counseling opportunities, as well as the delivery planning. And management requires a multidisciplinary approach involving the fetal medicines specialists, as I have alluded earlier, and other departments. So in low resource settings, strengthening antenatal ultrasound scan services and referral systems is essential. So this, I would like to thank you for listening.